Dr. Nate Keiser, welcome to Life After Impact, the Concussion Recovery Podcast.
Absolutely. Thanks for having me. It's good to see you again.
Yeah, I've been wanting to have you on the show for a while, so I'm glad we made this happen. And I'm excited to have you explain a little bit more about what you do and your unique specialty, which is very much at the crossroads of helping people with autonomic nervous system dysfunction, dysautonomia, and also dealing with persistent post-concussion symptoms. But why don't you start out and just give us a little bit about your background and how you got into this?
Sure. I'll do probably the quick one or everybody will tune out. But yeah, I got into neurology. The earliest story was actually I was in college and was headed down the road of going into prosthetics and orthotics. I don't know if I've talked to you about this before, but
I
I
don't
had a
think so.
friend who was really struggling. And back in, and I'm not that old, but I'm a little bit old. Um, like internet wasn't great. And so we were looking, trying to help and to see like, is there anybody that can help her out? And I came across these videos on a PBS broadcast of Dr. Carrick and ordered them VHS, got them in. And at that point, it was kind of like he was doing something that, especially at that time, was so foreign from anything that seemed like what anybody else was doing. And so I was like, I got to figure out what this guy's up to. So I kind of dropped my whole life at that point, learned he was a chiropractor. I went to chiropractic school to just follow what he was doing. And I just kind of kept doing that for a really long time. And that ultimately led to me being able to teach for the Carrick Institute and teach neurology. And then had the opportunity to work with him in Atlanta when that was available. And just like the biggest gift of my professional life was just being able to get to work with him. And in the process of that, like he was, as you know, probably a lot of your audience knows, was just like on the such a forefront of what was being done in concussion. Most of what anyone in any profession does now in the field of concussion comes from that work. And I got to watch him do it. And but in that time frame, one of the things that we noticed was that in that cohort of people, the ones that had the longest duration, they were the most stubborn symptoms, were the ones that had this corollary of having these autonomic compromise. And that is usually evident for a lot of people. If the easiest place to notice it for them as a patient was in their heart rate, like these high heart rate spikes, and then kind of like the ancillary things that would come with that. But that we were kind of charged with, we have to figure out what it is about these cases that we have to modify what we're doing to get to the same outcomes that we are with the other people. And that's like the second phase of my journey came with trying to understand that difference. And then that led to kind of what you're talking about, the pursuit of using some new technology that was available, trying to understand a little bit more depth about what's happening in people when we see these, you know, tachycardic responses, but it's not really just tachycardia. It's kind of a whole slew of things, but that's where it stemmed from. And so that's kind of what brings us to today, is just the continued pursuit of trying to solve that problem for as many people as we can.
Yeah, amazing. And in your clinic, you typically do 5-day intensives, right? Where you get to spend a lot of time on the front end doing some pretty comprehensive testing and then see people through an entire week of care. And so, why don't you talk a little bit about what is the process when someone comes to see you? You use transcranial Doppler ultrasound, which I just love. I think because when I was in my doctorate program, I had to do well, I didn't have to. I decided for my thesis to do a clinical trial as, just a student. Why not? And so I actually hired a transcranial Doppler ultrasound technician, and we enrolled a lot of MMA fighters, and we were comparing blood flow changes in MMA fighters compared to other people that were just exercising to see, okay, when they're actually sparring and receiving head contact, how is the blood flow changing? And so that was my kind of doctoral thesis. And so I'm familiar with transcranial Doppler ultrasound, but when you were demonstrating how you use it in the clinic, I was just so fascinated. I thought that was really cool. So why don't you talk about that too?
Sure, sure. So there's a few pieces I'll try to time together. Actually, a lot of people that see us end up staying, you mentioned 5 days, end up staying with us a longer period of time So if that helps level set for people, a lot of people stay 2 and 3 weeks with us
Hmm.
because so there's this element of if you are a person that is dealing with an autonomic problem, it's not your choice. It sucks, but also all of the healing requires blood flow. It requires adequate circulation. So if we're in this group of people that we're demonstrating like it is not going great in that field, we have to like rebuild and restructure that whole thing first to get then on the road of healing. So it's almost like we have to bolt on this whole first section before we can start to really like push them toward health again. And so I think if we just understand the problem we're trying to solve for people and are like able to measure it, measure improvement, then you kind of open up to like, well, what is the problem we're trying to solve? And then we'll just help you do what it takes to solve it. That's where we start from. And then our process kind of looks like we do a lot related to transcranial Doppler ultrasound with people, both in terms of autonomic findings, but then you also see people that don't necessarily know they have those problems, but may have just like persistent symptoms and things like you've seen, like concussion, but even people with neurodegenerative conditions, there's a lot of orthostatic or like when I stand up, a lot of problems that come with that. So we really try to pin that down for a lot of people. We use transcranial Doppler ultrasound and we use that in a dynamic way. And actually there was like the route, you'll appreciate this because you did it in the research, like the route to get there was not obvious because a lot of what was done when we started was you had people using SPECT scans of the brain, which is pretty cool. And that kind of gives you, you can follow a radioactive tracer around and kind of see where it's being uptaken in the brain. And that's pretty cool because it gives you a secondary sense of that. And we looked at, okay, fMRI and bold technology. That's kind of cool too, because you can look at changes in blood flow in that moment. But then we came, like the crux of the problem was we couldn't move people. And we couldn't have people doing things in the fMRI. We couldn't have them stand up. We couldn't have them stand up in the SPECT scan. And then we found other people that had been using transcranial Doppler, and you can put people on a tilt with it. You can have them up and moving around. You can do different tasks and see things change. You can have them move head positions and change. And so you got to do all this dynamic testing. So you're like, this is sweet. But then I had the moment, and maybe you can relate where it was like, why isn't everybody else doing this? And I thought like there must be something wrong with like something I'm missing something about this technology. And so I just went back through every piece of literature I could find, like from early days when they were, just figuring out how to like, duct tape it on people's heads and see what would happen. And I couldn't figure it out. Obviously there's, people will talk about some relationships with capnography. So we buckled that in and it's like, okay, we'll solve for that problem. And then like with vessel changes with, middle cerebral artery flow, but like we're doing it dynamically. So we're going to have those anyway. And then, so we just worked through it like that and have gotten to a point where that has become kind of a core feature that we are comparing against our functional exam, same way a lot of other people do. But it helps us to correlate the two things and understand. One of the big problems we were trying to solve early was when you look at somebody and you look at a test. So if we're looking at an eye test, we're looking at an eye movement, that's pretty common, or we're looking at the way you move your hands or the way you balance. We want to understand, is that something that is wrong because we've had that injury to that pathway in the brain? Or is that circulation failing and then not feeding the pathway so the pathway will fail? So in other words, is it a healthy pathway that is just running out of gas and failing? Or is it a damaged or injured pathway that we want to correct for? And we're trying to understand that. So in most of the cases we're looking at, we're really trying to make that distinction for people.
Yeah, and I guess maybe let's take a few steps back if people have no clue what we're talking about when we say transcranial Doppler ultrasound. Why don't you just explain what that is and what that looks
Sorry
like when
about
you're
that.
hooking people up to these devices and what you're actually measuring?
I'm going to blame that oversight on you for taking me straight into research nerd territory.
Yes, yes.
We're going to
My
bring that
fault.
up. But transcranial Doppler is, so most people are familiar with like an ultrasound. You might hear a baby's heartbeat or get some imaging from. And so you take those and you just take two little ones and you put them right on this little window of your skull where your bone's a little thinner. And you can actually shine that, or shine is a loose word, but you can send that ultrasound in and it will reflect back a sound image of what's going on. So we can measure the velocity of the blood flowing through. and we measure it through these two arteries, the middle cerebral arteries that are like the main tree trunks going into your brain, which is pretty slick. You can do it in other places as well, but we put you in kind of like a headgear so that those probes stay fixed, so that if you move around, it travels with you. So we can always measure you against you. So we get a baseline of you laying down, and that's you. And then we want to measure that against what happens when you're upright, and what happens when you move, and what happens when you do math, and all these things. So we can see, relative to your baseline, do doing these things make you better? Do they make you worse? And then does it change one side versus the other? What's going on? Does it come back? All these sorts of things. And we look at all those variables. So that's transcranial Doppler in a nutshell. Um, Anything to add from your days?
Oh, as an acupuncturist, I think that a lot of the reason why we see neurological improvement in people after an acupuncture treatment is because of certain acupuncture points that help to improve blood flow through that middle cerebral artery. And so I feel like, just more, again, more of like the research nerd in me would love to be able to do more studies looking at transcranial Doppler ultrasound and the effects of acupuncture on blood flow to the brain, because I think that so much of the beneficial outcomes are related to that. And like you were saying earlier, it's important to tease out if somebody has certain symptoms and they're struggling with certain movements, or there's some kind of deficit in their output. Is it because they don't have enough gasoline? Is it that they're not getting enough blood flow, or is it more of just a functional pathway that needs to be corrected? And so answering that question is so important, because I'm assuming that once you have that information, it really changes your treatment strategy.
It has changed profoundly how I practice now. To be fully honest, everything changes a lot because in two ways. Number one, in terms of the outcomes that we're after and being able to change that product for people to be able to get blood flow to their brain. But then also in terms of, you can recognize things in a different way when it's not going well. In other words, if people are doing the things that seem right, you can catch these little anomalies that are really hard to catch otherwise. Like, you would have no basis for understanding them without being able to kind of look into the system,
Hmm.
which is humbling, because it also kind of shows you where a thing that you might have leaned on a lot as a way to, like, I think this is how we solve this. It can change that relationship where you go, ooh, I mean, I need to look at this differently. And so that's been rewarding because it helps me to, like, kill my assumptions that I'm going on, that things. Charlie Munger always said, your most dangerous assumptions are the ones you don't question. Right. So, like, the things that you know for certain are the things that are the most dangerous things for you to think about. So it has helped me a lot in being able to understand, like, the things I thought I knew, maybe I don't know. And then now I can solve that problem better because I have a new way to look at it. If that makes sense. I don't know.
It does, yeah. And I think the other question I had, and this also ties into the fact that in addition to looking at blood flow to the brain, you're also measuring carbon dioxide. And so I wanted to have you talk a little bit about that too, because people end up kind of in a cardiology office where a lot of times things are looked at from a how do we pharmaceutically try to stabilize the system. And then there's obviously all kinds of different approaches and avenues, but one of them being, I think, as a chiropractor with that background, you're probably also looking at your C1 vertebrae and rib excursion and breathing mechanics, and you're also looking at it from a structural and an orthopedic perspective. And so I imagine that having these data points also informs you on, gosh, like how much is someone's breathing mechanics impacting blood flow to their brain and impacting oxygen and carbon dioxide and all of these other aspects of function. So I'd love for you to touch upon some of those findings too, and how you've been kind of playing around with treatment
Yeah.
and observation with that data.
That's a really good point. There are two separate things there. One's with the carbon dioxide that we should cover, but first I want to cover, like, the structural side, because because I went into chiropractic school with full intentions on, like, I was interested in neurology. And so the skew in my mind was really a lot more toward what is happening in the brain. And over time, I've actually come around a little bit and noticed, and because of this, really, what we talked about with the Doppler, have noticed that there is so much more happening in people with neck injuries than we give them credit for. So a lot of times you get a whiplash or you fall on the ice or you have a sports injury or pick your thing. We think about brain or we think about your neck, but we don't think about like, well, maybe, your neck isn't like the main like complaint that you have. But also when you turn your head to the left, the blood flow in your right middle cerebral artery goes down by 40%. So like it's kind of both. It's like it's in your neck, but it's also your brain. And we have to match these things together because if we don't resolve that for people, I mean, that's where people get stuck is you can do the exact right thing in two different places. I can go to my chiropractic neurologist who's doing their thing and like giving me these great eye movements, but then I can go to the PT who's helping me, do chin tucks and help my neck, and I can do those separate. And then they just never get to the point where we address like, well, actually, it happens here when you turn your head because there's an asynchrony in the movement, and that breaks the whole thing down. And you have complex migraines, and you can't talk, and your hand goes numb, and you can't walk. And so that was a humbling experience in terms of like coming back to that structure in a major way.
Hmm.
And it has been unbelievable. If you were to ask me 10 years ago, like what percentage of the people do you think have problems just with kinematics and the movement of their head and neck? I would have said, I don't even want to embarrass myself with a number, but relative to like what it actually is profound. We see so much of it. It's incredible. And I would have never guessed that. And then the second part of that was talking about CO2. Um, One of the things I think is really cool, and for anybody that's a clinician or just an interested patient, as you mentioned with acupuncture, being able to change a feedback loop changes that reflexogenic control so much. But what we don't think about with blood flow is like it's all reflexogenic. It's all just reflexes. Like it's really actually hard to like in your mind shift your blood flow. There are some monks that can do it. There are some people that can do it, but they don't do it by saying, I'm going to bring blood flow here. In a lot of ways, they do it by what they think about and where, like if I imagine a place enough, I can stimulate blood flow to the area of my brain that's going to represent space. Or if I move my arms, I can do those things. But it's really hard to do it and then just, I'm only going to think about, I'm going to pull blood here and do it. It's so reflexogenic. And the two main reflexes that are in autoregulation, which is the actual vessels themselves respond to how much stretch is being put on them by the blood inside, which is amazing. But then that's coupled to the level of CO2, which is just wild to me because everything we know about surviving is that like you got to have oxygen. And your body's like, but you know what we're going to measure? Carbon dioxide. And it's like, we're going to judge if we're living by CO2. And it actually makes sense because it's it's like the exhaust of the cell. So like the same way a gas car is going to give off exhaust fumes, that is the exhaust fumes of our cellular respiration. So like any cell that is working, it gives off water and it gives off CO2. And so the way your body is measuring if something is active and working is by detecting the CO2 that's coming from it. So it's like looking at exhaust coming out of the exhaust pipe as a way to know how hard that cell is working. And then the reflex to that is like the more CO2 there is, the more we're going to open up and flush more blood in. But the less CO2 there is, the more we're going to restrict the flow because we're not using it. And so in a lot of people that we see, there are errors in the way that these reflexes are correlating to each other. They can be for lots of reasons. We saw a huge influx of them when people had both, viral catalysts, but then also iatrogenic catalysts, which are coming from trying to solve the viral catalysts. And, these things where it actually damages the endothelial lining of the tissue of cells. So people will talk about endotheliitis or, problems with the endothelial system, and they'll talk about, nutrients moving across and I'm inflamed and talk about those things. And those things are all valid. But maybe the more important part is like the fundamental reflex of the endothelial system is to control how much blood is going in and out of especially brain tissue at any given moment. And being like when I got to read about that for the first time, that was something that like completely broke my brain, first of all, in understanding the profundity of it. But then also it was just kind of like I can still remember where I was sitting in my office reading, I was preparing for a class to give a class and reading this thing, and I just like sat on the floor and I was like, this, why don't we not talk about like why aren't we talking about this all the time? And and then the second part of that was like, this is a thing that you can change. Like very like you could change this to people. So why aren't we doing this? And that's kind of been consuming ever since that moment on the floor.
Yeah, I mean, I would say I had a similar response to when I was watching you during that clinical theater and watching these changes in carbon dioxide levels and seeing these uh low carbon dioxide levels on people. And I, in my mind, I'm like, why is he like the only one in the country looking at this? And so talk a little bit about how do you change that when you see these reflexes that are not working correctly and the whole entire system's wired in a way where it's not responding appropriately to carbon dioxide changes. What are you doing? How are you kind of unraveling this?
That's a great question. It's been a journey because most of the work that's tied to that with CO2 levels is tied to breathing rate and rhythm. And that makes sense, right? So most people have seen somebody hyperventilate. It's like if you breathe really fast or if you breathe really deep. So a lot of people, I bet you've had people relay this. Like you breathe really deep, but then I feel lightheaded. And so both of those are instances where we're breathing too much. And when you breathe too much, your carbon dioxide levels, you're breathing it out. So you're breathing it out too much. But like the magic of your brain, of these reflexes, is that your breathing should just be tied to that number. So whatever your current breathing rate is, should be in support of managing that CO2 level. And so we think about all the ways that we manipulate breathing, and we think about all the ways that we experience shortness of breath, or we experience air hunger, or arrhythmia in breathing. It doesn't feel right. I can't catch a deep breath. But they all should be tied to just like one kind of very simple reflex. And so if our body isn't able to use that chemoreceptor, like the ability to sense that chemistry well, the whole thing gets skewed. And so when you see these breathing arrhythmias, then you're looking at whether it's subtle or huge, you're looking at an error in the way that your body is trying to manage the system, which is a great tell. But it's also a great thing to be able to point to because you've got these big territories in your brainstem that are in charge of being able to calibrate it. And their job is to calibrate it dynamically. So it's not this thing like your brain's set up and then it just stays that way. It's supposed to calibrate it all the time. You know this. This is the basis of neuroplasticity, right? So it's supposed to be constantly fluctuating. And if it's not, it's telling you like it has lost the ability to constantly fluctuate. So we can use this as an example, but it kind of extrapolates to kind of all neuro rehab in a way, is this concept of dose matching. So you have to match the dose of the activity to what somebody can do now. So even if I can't, you take somebody that's dizzy, right? If I'm dizzy all the time, but maybe I like lay down in a certain position and breathe a certain way and I can get like a moment. Okay, that is the amount of gravity that that person can tolerate. Okay, so there is an amount that they can tolerate. And same thing with breathing. So maybe it's not enough, like you can't tolerate walking around. Okay, fine. But can you tolerate laying down? Or can you tolerate if I, arch my back in a certain way, or if I tilt my head in a certain way and I can breathe like that? That's your starting point. Just like, Ayla, I know you're strong, but like if you were going to try to be like, my next goal is I want to bench press 300 pounds, we wouldn't stick you under the bar with 300 pounds and say, let me know when you got it. We would say, like, where are you starting at? And then we would start there. And then we would build it gently, bit by bit, but you would be able to do it. And if you wanted to, and you wanted to work hard enough at it, you could probably do it. And so it's the same thing when we think about any dose response, whether it's with acupuncture, this, and whether it's with neurorehabilitation or it's physical fitness or it's learning math or it's learning a new language, the dose is the thing. So we want to do just above what you can do and then let you get enough rest to where you can assimilate it and then do it again with another space of repetition. And then you do it again and do it again and do it again until it's easy. And then you make it harder. And it's so simple, but we don't really do it. Most of our rehab techniques in like general world are built on like fitness level. Like we're just going to try to do a lot. And if we can do a lot, hopefully that lifts you to that point. But if you're not there to where you can do a lot, then the dose is too big and we make you feel worse. And so I think for most, like if you've got practitioners out there or if you've got patients that are kind of like in that struggle, the first question is like, am I getting the dose right? And a lot of times we're just doing too much and we have to back down and like do the easiest, simplest version until you can do it well and then build up from there. That's a
Mhm.
bit of a tirade and a rant. I apologize, but hopefully it's useful for somebody.
Yeah, and it's very on point as well. I would say that when I started to really dive into dysautonomia, that's when it started to make sense to me, all of these patients that would have what I might think is a paradoxical reaction to a therapy. And it was like, there that was just the dose was too much. And then all of a sudden things become crystal clear on why somebody can't tolerate X, Y, or Z, and you gotta kind of back off and rethink your strategy and start over again.
Yeah, but you can do like I'm guilty of this, especially early on. Most health care practitioners, as you know, are governed by this like intense desire to help. And like if you are doing a thing and it is not helping, the reflex is to do more. And then
Hmm.
you just watch it continue to work its way down. And I've experienced that too. And yeah, more is not usually the answer, unfortunately. It's usually almost in when we think about chronic cases, it's almost always less than you're doing right now.
Yeah. And so does that mean that while you're monitoring all of this information, that you are trying to find certain breathing rates that work best for certain individuals?
Yeah, that's a good question. Sometimes yes, and sometimes no. My ultimate goal for most people is to make it so you don't have to think about breathing. Because if you got to control your own breathing, it's not quite working. And so we will use it sometimes as ways to like augment the moment. Like if we've broken it to a point and we've got to pull things back in, we can give them different breathing things that we do. It's not always just like, breathing in and out at a certain pace. A lot of times it's changing the position of their body. So like getting, like accentuating a lumbar curve or accentuating a cervical lordosis that allows you to be able to use your rib mechanics better. That's a big feature of what we'll do because so many people, when they don't feel well, just get into these positions where it's just really hard to catch the breath. So we'll actually change position more than we change rhythm because we want the rhythm to be a little more natural. But feedback has been really helpful in terms of we can give someone a CO2 monitor and have them just breathe how they're normally breathing, but see what that looks like
Mhm.
referenced through the CO2. And then like, can you find a way to just slow your breathing pattern down a little bit? We'll usually give them some somatic cues like what you're doing with your body and see if we can pull those values up. And then once they're back up again, we'll kind of move back into whatever we're doing. And we might use that as a way to say, like, all right, we're going to do this. Once that level drops, you're just going to focus on it, let it come back up, and then we'll come back in. And we just work back and forth like that, trying to keep people in that tight range, which, especially for people with MECFS, um, things where like energy is at a premium and they don't have a lot to give. We will use that a lot of times as ways to just start to coax people back into their life again, but then also use it as a way to because so many people had the experience of, I don't know I went too far until tomorrow.
Mhm.
And so giving them a way to be able to measure that moment before they actually do go too far uh, is really useful and it's empowering because you have something you feel like you can kind of trust a little bit. It's outside of like the way I feel, and that can be helpful to feel comfortable pushing your pace a little bit.
Absolutely. Yeah, you're right. So many people know that they want to be able to kind of achieve a certain goalpost, but then there's that fear of, well, gosh, it's like I feel like the line in the sand changes every day, and how do I know where it is today and how that's going to maybe throw me off tomorrow? And then I feel like I have a huge setback, and it can be a very frustrating process for people.
Yeah, you hit that well for sure.
Are there CO2 devices that do you have certain ones where people can just go buy them, use them at home?
It's a good question. It's kind of a gray space because for a lot of them, you're supposed to be a medical provider.
Mm.
Um, but there are a couple that you can, if you are savvy with the internet, that you can find um, that are really useful. And we will let people know that they exist. But again, it's kind of a gray space.
Sure.
Um, as a way to kind of manage that at home. It's actually a really good tool. I wish it was more available. We need in your spare time, if you want to build one that is like a patient facing one, I would love
Yeah,
that. I'd be very
sure. I'll
thankful.
I'll just add an eighth day to my week and we should be good to go.
That'd be great. That'd be great. So we'll get that out like next month then. And
Okay, great.
but it is a useful tool, especially as you're pushing pace and getting more capacity. Looking at that CO2 monitor can be really helpful um, as kind of like a go no go, especially you wake up in the morning one day and it's like a little low to start with. Time to get back to work, bring that in, and get going that way. So, um, yeah, I like that tool. I like a lot of tools. We've been actually in the role of improving things. We're always trying to figure out more things that we can give people to go home with that are objective rather than relying on the way they feel.
Mhm.
So that they know like day by day as they're working through these skill sets, um, they have their own ability to chart their path, which is obviously really useful because we want to get people to autonomy as fast as they can. And I'm sure you're in the same boat. So giving people things that are objective, say, okay, it's got to stay, you keep it in this range, or your eyes shouldn't deviate when you move this way, and then just helping them stay in range like that.
Yeah, I came across an interesting, I will say it was maybe, I'll call it a statistic. It was in a research paper, but this was an online survey of people that had already been diagnosed with a form of dysautonomia, and 63% of them reported that they had had essentially certain signs and symptoms for most of their life that something was maybe amiss. And so I wanted to talk a little bit about this concept of, dysautonomia is never a black and white thing. Our autonomic nervous system it's super complex. It does so many different things. Now there's just so much information on the internet, lots of people kind of trying to figure things out, but maybe having certain misconceptions. Um, how often do you pay attention to kind of the timeline of, does this person maybe currently now has dysautonomia, but how much do you dive into their past in terms of, did you faint when you were a kid or a teenager, or did you have a lot of dizziness, or like, I'm just always curious on how long has these little maybe errors in the system, how long have they actually been there? Do you pay much attention to that?
I think that's a really good insight. I think because we talk about things so much in terms of symptoms, and so dysautonomia kind of represents symptoms to a lot of people,
Mhm.
that it becomes a monolith, right? Like everybody, like dysautonomia is just kind of like the same. Like your dysautonomia and mine are the same. We're buds. Um, so as I would say, the first part of that is to just recognize that it's not. It's just a way that we use as a shorthand to describe what you're feeling. But as soon as you even start to use words, you're not really accurately rendering what you're feeling. You're using a word to describe something that you heard somebody else say or you saw on the internet. And it's really like language is a hard way to describe what's going on inside you. So that's number one. And so my encouragement for a lot of people is to not get stuck there and is to consider more what is happening. What is the mechanism? Like what is physically happening in your body that is causing this error to occur? And like that's a way better language to start from, right?
Mhm.
So if you do it that way, then you realize for most people, there is a catalyst. There is a moment when I could no longer duct tape this thing together anymore and it breaks, so to speak. But for a lot of people have all these breadcrumbs through their life of other things that happen. Like, um, I have not talked about it publicly other than we just published a video for the first time a week or two ago about my experience with that. So I had, different things happen where I ended up having to get heart surgery because I had a problem in this realm. And there was a catalyst for me, but if you go back in time, like I had an episode after, a thing wrestling, we went on, I had wrestling practice, had a thing happen, and then went on vacation with my family, was laying on the floor, stood up, tipped over backwards and fell through a glass table. My mom yelled at me. I could hear her. I couldn't see anything. She's like, "Stop screwing around. You're gonna break your grandmother's table." And so I like passed out, but then like it was fine. Went to Disneyland, did the whole thing, or Disney World, and did the whole thing. And then later on, had another fracture in my neck that we didn't find until later, and then had, problems that ended up causing arrhythmia in my heart and blood flow problems in my brain. So
Mhm.
like I've lived a lot of this life that in a way
Mhm.
that I haven't talked about. Um, but in my life, there's looking back and seeing like, oh, man, that stuff was happening kind of all the way along through there. And then it finally got to this point where it was like I couldn't do it anymore. But then in the solution phase, like, so I ended up with a problem with the rhythm in my heart. I had AFib, and it was drastically impacting the blood flow to my own brain, ironically, before I had any Doppler testing. And that was a big deal for me. But I ended up getting a heart surgery. And so for most AFib at that age, young AFib, lone AFib, you get a heart surgery and you're like generally fine. You're pretty good. But I wasn't. My heart went back into rhythm, but I had a long process of getting strong again. Like it took me a year to get back to like any like semblance of strength. I had to go back through, working, seeing one patient at a time and taking naps in between cases and
Wow.
on my way home, stopping at Costco, laying back in the car to like get enough energy, and I would go take one lap around Costco and then back in the car and have to rest and then drive home, and I would just expose myself to that trying to get stronger. So I've done all of these things. And but the portion of that matters, like when you think about history, is it's really easy to think about the catalyst, the thing that like was the most recent problem. But as you mentioned, for so many people, it's a culmination of a life well lived. All the adventures and all the mistakes and all of the interesting things that happen, they come with just these little augmentations to you that make you who you are, but then they also can have an effect on that physiology. But if we don't understand them, it's really hard to solve it. So like in my scenario, if we would have just said like AFib surgery, there you go, good to go, why are you still having these problems afterwards? Your heart looks great. Well, it's because of all the other stuff that happened before that, that when the heart part went bad, all that stuff starts to show up now. Um, and so I get to, I feel in a very visceral way. And so it's very easy for me, but um, like if you've not experienced that before, then it's kind of hard to pin down where it is. But if you can organize it and say like a lifetime of things, write the whole thing down. When you go to the doctor, bring everything. You had your tooth pulled out. Let's check that sucker out. Let's see what's going on. But I think that part, if you're willing to spend the time on it, can unlock a lot of mystery in people that you don't think about.
Yeah. And I think the other thing that doesn't get talked about enough is the brain's role in controlling heart rhythm and heart rate. And I think what was so visceral for me to watch was when Dr. Carrick was doing a clinic theater and he had someone's heart rate, their heartbeat was hooked up to a speaker so you could hear it. And he was doing a specific right cerebellar activation technique and you could hear the change in the heartbeat. And it was just one of those moments of such a beautiful way of explaining the heart. It doesn't have its own brain. It's actually getting its feedback from our brain. And now, originally we thought the cerebellum just controlled our limbs, and now we realize there's all these really important parts in the middle of the cerebellum that dump into the brainstem and control our heart rate and our rhythm, and it's all connected. And I think that it's still something that we don't talk enough about, the role of brain function on heart function.
Yeah. It's can I tell you a quick story about Dr. Carrick? So I know that exact video that you're talking about. When I first started to teach for Dr. Carrick, I was reasonably young and so very nervous. And they would give us this list of like, what do you think your strengths are, and what do you think your weaknesses are, and what courses do you think you'd be the best at, and what courses do you think you'd be the worst at. And so I never really said like I'm really the best at this. That's not really how my mind works, but I knew which one I was the worst at, and it was neurocardiology. And so you can guess what the first class I ever taught was neurocardiology. And,
Neurocardiology.
yeah, and and so I taught that one terrified, and I worked harder on that class than any other one that I taught in that kind of section of the curriculum.
Hmm.
And but what it taught me, I think, is what I'm still talking about now. Is still from that course of understanding like that dynamic, the same way like everything is constantly being controlled all the time. And like beat by beat, your brain is controlling the whole show. And if it doesn't, just like a little, like you have a baby, the baby's heartbeat is about 100 to 120 beats per minute. And in an adult, we look at that and go, that's not good. If we cut all the wires from the brain to the heart, and your heart just is going to do its thing, it's going to beat around there. And so what you're literally looking at with a lot of people with tachycardia is that disconnection of the brain's influence over the heart. And the primary places that exist are not so much in the things we think about, but they're in all the stuff that we count on. And as you mentioned, that cerebellum is like the main feature of automating thing. It's almost like our own internal AI, where it's like everything that you want to automate in your life, that's the cerebellum's job. So you give the cerebellum an idea, and it's like, I will automate that baseball swing. I will automate your gait. I will automate the way you drive to work. It's like I will take over everything that you don't want to think about. I got you. But it's also the thing that is control, like perfectly controlling the entire autonomic system, which is beautiful.
Hmm. Yeah. When we, again, going back to like learning neurology, and we learn about the different lobes of the brain and how can you kind of functionally assess these different lobes of the brain. So we have all these different ways of assessing different parts of the frontal lobe and the parietal lobe and the temporal lobe. And then we have this thing called the insular cortex, right? And I was like, gosh, this is such an important part of the brain. Again, something that I don't think we talk about enough, something that I think acupuncture really modulates in a way that's unique. And I finally came across, because I have patients who have increased heartbeat awareness, right? So I'll have people come in and they'll say, I think I'm having tachycardia. And when I pop my heart rate monitor on them, it's like, well, no, your heart beat is 60 beats a minute, but you have increased heartbeat awareness and your heart is like pounding, but it's not pounding fast. And
Sure.
so and obviously there's a lot of things involved with that. But one of the ways to functionally assess your insular cortex is, can you sit there and close your eyes and count how many beats per minute you can feel your heart? And I was like, okay, finally, I found my functional test for this particular part of the brain. I love it.
Yeah, I remember that test. Yep. Yeah, the insular cortex is amazing. And as a note for you, so the first paper that I read that coupled um, kind of the posterior insular cortex with what we were looking at with vasoreactivity in the body in a way that was regional was an acupuncture study. It was the first one that I could ever grab onto that like showed, because amazingly, I mean, this is probably 15 years ago, but amazingly, no one had ever shown you can you can cause different blood flow in the body by changing activity in the brain, right? So like it's not all one, it's not like all one blood flow. It shifts based on what's happening. And I think people understand that better now. But that was the first paper where they looked at it's segmental, it's regional, it's distributed version of being able to control this. But you can only do that if you have an accurate rendering of what that body looks like,
Right.
which has to
Which,
work together in an
yep.
internal representation, right?
Yeah, and acupuncture is incredible for remapping the body in the brain, but not just remapping muscles and limbs, actually remapping blood flow.
Yeah. Well, it's the same map. So that's what that paper showed was the same map for how people will experience, all the way down. So if we take a biopsy and go skin to muscle or skin to bone all the way through, and we've got that little sample, all of those things are integrated in your brain in terms of what they are experiencing. So if I have like a peripheral neuropathy, I don't feel my feet. If I can't feel the skin on my feet, there's a high probability that I'm also not going to be able to control the blood that flows to them either. Same way I'm not going to be able to control the strength of them. In the same way I'm not going to be able to maintain like the hair that covers that area or the sweat that should be on that area. And that paper, I wish I could think of the author right now, but was the first one that was like, yes, there it is. And so tying it back there and moving from that insular cortex out is actually a really useful tool when people are trying to understand how, like what we just talked about, especially with neuropathy, being able to figure out like how is this thing that is happening peripherally, right? So undeniably, it's a peripheral nerve problem, but what is that doing in the brain? And so often, if you have someone that's got a neuropathy or has a problem in the periphery, we almost don't even consider what that's doing in the brain. Do you find that too?
Um, I think I am looking at it from a similar perspective. And what's really cool with acupuncture is that your needling technique can change whether or not you're stimulating. So if obviously with our nerve fibers, we've got our sensory motor and autonomic fibers in the nerve, but your needling technique can actually change which of those fibers you're stimulating, whether you're stimulating a sensory, a motor, or an autonomic. And so that's where I think that, again, from a high level acupuncture perspective, needling technique is very important and can actually change how the body's going to respond from autonomic, motor, and sensory perspectives.
Hmm. And what's cool is, so maybe I'm going to interview you for a second for the audience. So when you're looking at that and when you're trying to explain that to other people that are doing, whether it's, because I know you teach, so whether that's in other people that are wanting to do acupuncture or whatever their choice of tool is,
Hmm.
how do you relate to them how to think about that technique versus how do they know what they're hitting? So are you giving that, do they have a way to be able to kind of like capture an objective on the other side of that to keep them moving forward?
Yeah, so there's a difference in needling where you would feel a sensory kind of like tingling
Uh-huh.
versus a motor twitch, for example. And so I can needle the same point and I can get a sensory sensation of tingling, or I can get a motor sensation of um, an actual twitch and maybe a movement, or I can be simultaneously feeling their pulse and feel a change in their pulse when I needle. And so when I'm doing, for example, like stroke rehab, if I have somebody with paralysis of their arm, I will be feeling their pulse on one part while I'm needling another part, and I'm waiting until I feel changes in their pulse to know, okay, I'm having kind of this change in autonomics here based on my needling technique. So I would say that's kind of how I teach it, is that you can distinguish these things by actual physical reactions.
Right. I'm glad you described it that way because I don't think it, I don't think it's tool, it's kind of like tool agnostic. So same way you can do that with acupuncture. People can be thinking about that if you're a PT and you're applying it, you're doing a stretch or you're, doing a movement of the limb. you can see if the motor response is changing. Like you talked about a twitch, but like tremulousness is the same idea. Or you might see like an abnormal flushing in that area, which is kind of like a skin vasomotor response versus a pulsatility one. And so I guess, yeah, I guess I bring that up to kind of point out, um, I may talk about it through my language and you talk about it through yours, but we're all really kind of speaking the same language. And if we can just extrapolate that out, you can think about autonomic systems in the application of almost any kind of a treatment strategy. And I think it's useful that way because it points back to dosage and it points back to getting that traction.
Yeah, and one of the cool things, because as I, with my Chinese medicine perspective, study dysautonomia, and we look at the Compass 31 questionnaire, and it's broken down into kind of six basic domains of autonomic function, you can trace those six domains of autonomic function back to what we call the five functions of qi. And so we have these different kind of functions of containment and regulation and fluid dynamics. And so it's one of those things where I can have a patient fill out the Compass 31 and I can look at it from a neuroscience perspective, and then I can look at it from a traditional Chinese medicine theory perspective and say, okay, here are the different aspects or the different functions that aren't working in the body. And then what's cool about that is that then you start to look at, for example, somebody that has POTS. Well, we know that there's different mechanisms that cause that. And if somebody's having excessive surges of norepinephrine, that would be a very different treatment strategy than somebody that has a hypovolemic cause for the tachycardia. And so you can start to look at the mechanisms kind of driving a POTS presentation and realize that the actual TCM approach would be completely different once you understand those different mechanisms. So the like your experience of the more you learn neurology and neuroscience, the more you see, oh my gosh, if I start to change the kinematics, if I start to work with people's like actual physical structure, it changes their brain. And same thing with me. It's like I went through this journey of learning functional neurology and then wanting to use all of these other tools like the eye and the head eye vestibular rehab and peripheral nerve stimulation. And then after learning all of that and playing with all of that, I come back to the power of, oh well, what happens if I just stick an acupuncture needle right here? Oh, look at what changes. And so it's like I had to almost like set aside what I had known and go learn all this other stuff in order to come back to what I had learned originally and then integrate it all together.
Yeah, I think that's a really good. I think that's a good message for a lot of people learning just in general. Um, and I think that's wonderful. It's interesting to me. Um, so Chinese medicine is actually a really interesting thing in terms of its relationship to Western medicine. But more importantly, it's like maybe not Western medicine as much as like just neuroscience. I think you put it that way. Um, is that a lot of what the language that Chinese medicine uses is very accurate in terms of how to actually think about autonomic systems because it's almost too generalized when you think about, well, you have a parasympathetic and a sympathetic system and they're opposite to each other, they're antagonistic to each other, and one is up and one is down. And it's actually a really poor way to think about it because they're really just two. We name them because somebody cut someone open and said like, hey, these nerves are all structured the same. And like, hey, these nerves are all structured the same with no relevance to the function. And actually the people that were early on, when you look at like Canon, said like these are physically similar because of where the ganglion is and the type of neurotransmitters they use, but they're actually like they're all distributed. They're all functionally different. So the ones that are going to control blood vessels are not, they don't have the same, they're not necessarily tied to the ones that are going to control sweating and not going to necessarily control heart rate. And so they all have these distinct functions. And I think Chinese medicine does a really nice job of kind of explaining that ability to be specific, but using terms, language. I'm going to get the language wrong, but using the language around like congestion and things as a way to say like we're having two systems that should act independently that are acting together, and they shouldn't be. They should be separated. And I think that I think that people have known about this for a very long time, and it's exciting to kind of talk about it in those terms. But in Western medicine, we've made it really gross in that like we think about them as antagonistic. So if I want, you mentioned norepinephrine. If I want my heart rate to come down, I need to do something that's parasympathetic. Those two things don't even matter. They're not even correlated in that way. If I want to change my blood vessels, your blood vessels have in your body have like zero parasympathetic innervation at all. So they're not related. But unfortunately, because of the way people think about it as one versus the other, a lot of at least the conversation around how to solve them is in that language, which really prevents people from being able to do a lot. Um, but I think the language that pre-existed was probably more useful.
Yeah, and I think it allows me to pick up on some things that, again, knowing the information on both sides has helped me to understand why would a patient say that they feel really, really hot, but their skin feels cold. And in Chinese medicine, we talk about all these concepts of like either buried heat or what we call like a yin deficient heat versus an excess heat. And again, it's like you use different treatment strategies based on whether someone's got just an excessive amount of heat or if they have more of a deficient heat and maybe that's trapped somewhere, and it gets back to this idea of the patient can't regulate the open and closing of their pores, and so they might have different sweating irregularities, but it's like once you understand the underneath that what's causing it, then you can have the right treatment strategy. And so we talk a lot, like Chinese medicine focuses so much on temperature and on the difference between vasomotor versus secretomotor functions, and being able to differentiate between flushing and redness versus sweating or not sweating. And there's different herbal combinations that kind of address all those subtleties. And all of that gets completely missed when you just kind of pharmaceutically try to come in with a physiological hammer and just shove the system one direction.
Hmm. Yeah, and it's been unfortunately a big barrier as we try to understand, not understand, but try to help people because the physiology that's wild. So we've been really lucky to test multiple people looking at they'll come in with either meds on or off, and we'll run through our battery, and then sometimes we'll see that and be like, like, for example, if somebody comes in with meds off, and they're like, I'd like to see what they look like on, and the things that you would expect based on, kind of the label on the box. It is amazing how often that's not what's actually happening in the physiology. So I'll give you an example.
Interesting.
We had one person that she was on midodrine. I don't know how to say it. Everybody says it differently, but it's basically a medication that should just, rather than you controlling beat by beat what the vessel tone is, it just makes it more constricted. Just hold. And when it does that, it's supposed to increase your blood pressure. And if your blood pressure is increased, then it should translate into more blood flow in your brain and you should feel a little better. And so we did that with her and we looked at the blood flow, the amount of blood flow that she had in the brain off the midodrine. And then we looked at it with it on. And amazingly, on the midodrine, the cerebral blood flow was worse.
Hmm.
So it was like you mentioned, paradoxical reactions. If anything, that her blood pressure is going up, but the actual response that's happening in the brain was fully decoupled from that, right? And so if you don't measure it, you have no way to know. And so she's taking this medication thinking like it should be helping my brain get more blood. She's looking at her blood pressure and her blood pressure is higher, but the amount of that that's actually transferring to her brain is less. So the overall volume is less. So yeah, things like that are amazing, but
Right.
it is the lowest friction solution for a lot of people, both in terms of like it's easy because you just pop it in your mouth, but also because it's what third party payers will pay for. And so that is like overwhelmingly what people are being exposed to. And unfortunately, I think in a lot of cases, it's like a swing and a miss altogether.
Yeah, and it seems to me like more and more when people come into my office, they're parroting their doctor saying is, "Well, my doctor said I should just try this." They're not really sure if it's going to work or not, but they said, "Here, you can try it," you know. And it just comes back down to like there is no protocol.
Yeah, let's try stuff, unfortunately. But I think if we can the wonderful thing about the exposure to information right now is people can get a much broader swath of information. That's why we get to do this. And I think if we can shift people toward thinking about like what is the underlying mechanism as a like a core driver of what I'm going to do, then I think people will start to trend toward things that are like that are more helpful, that have more of a positive outcome over their lifespan, rather than just in those little epochs of time where we can kind of manipulate chemistry. So I'm really hopeful for that, and that's obviously why we spend a lot of time talking about it. We built we call it it's a POTS roadmap where it just kind of gives people like all the steps of like where if you were starting from the beginning, what things would be useful to check, which things would be useful to talk to your doctors about. How do you move through that in an organized way rather than having it feel really chaotic and like I'm pulled in all these different ways, so that people can kind of like structurally start to look at what's going on here. And that's been something that seems like people are really responding to as a way to just like figure out how to navigate. Where do you start from? Is a big question for a lot of people.
Yeah, and I really do see a growing number of comorbidities between autoimmune disorders and dysautonomia, and I feel like those numbers are just skyrocketing.
Yeah, well, they have to because they're both governed by the same system. So, um, the same way the auto immunity levels are going to go up, the amount of difficulty with that digestion is going to tend to go up. The things you are sensitive in your life are going to go up. Your ability to control your hormone regulation is going to be impaired because all of these feedback loops require a brain that can feel what's going on in here and what's going on out there accurately and generate a motor response. And I think we skip that a lot in terms of trying to understand the way that those systems work.
Hmm. Yeah. So, anything that we haven't talked about that you wanted to
Oh, I'm
touch
sure
on
there are tons
today?
of things, but maybe for another time. No, I really appreciate you sharing, and I always enjoy hearing about the acupuncture side of the world, um, because I think it converges more than it diverges, so it's really helpful.
Hmm. Yeah, well, it's been interesting and fun to just really merge, you know, what I've learned through the Carrick Institute and Dr. Carrick and this functional neurology approach. So it's a whole kind of new frontier of neuroscience meets Chinese medicine.
It's great. Keep going. Let's keep doing it.
Yeah. Well, yeah, I think we'll have to do a round two here at some point in the future.
I'd be thrilled. That sounds great.
Awesome. Well, where can people find you?
If you search my name, it's pretty easy to find. Last name spelled Keiser, and that can be tricky. But Doc Kaiser on most things, like DOCKEISER. And we put a lot of stuff out on YouTube and just try to help people and give you some things to think about, research that comes out, and just keep people posted on opportunities to know more, learn more, be able to help themselves out of a bad spot. So keep
Yeah,
doing that.
excellent. Well, and your clinic is in an adorable little town in Chelsea, Michigan.
It is.
So you got a
We're
great
very
space there.
Thanks. Yeah, it's wonderful. We've got a great team. We are super blessed, and we're always trying to pull more people into that team. So just be aware of that world, and yeah, we'll keep going.
Awesome. Well, thanks so much. I'll put all of that in the show notes so people can find you.
Well, thanks. I appreciate that. It's great to
Yeah.
talk to you again.
You too.
Thanks.